Nurses in the critical care setting are presented with various challenges that necessitate the use of both clinical judgment and critical thinking. Each patient has specific needs that are affected by the disease process and has placed him or her in the critical care units. One of the unique challenges for nurses to help patients overcome is pain. Pain is described as simultaneously a universal human experience and deeply, intensely personal. In fact, the guideline for pain medication administration is that nurses are to intervene whenever the patient states their need for an intervention. Yet, in the critically ill patient, there are often many factors at play in making it difficult to assess pain, such as mechanical ventilation and sedation. These particular factors inhibit patient report and can lead to poor control of pain. These factors also contribute to a lack of nursing assessment, coupled with an oversight of the patient's pain. These circumstances become a greater issue in attempts to control pain in the neurological critical care area. In this presentation, we will discuss the physiologic effects of pain to develop a deeper understanding of what your patients may be experiencing. We will further discuss assessment guidelines as well as management options to promote more patient advocacy for controlling pain in this challenging environment. There are numerous processes occurring in the critically ill patient all at once. When a patient is in pain, these processes can become even more detrimental as pain negatively impacts all systems of the body. Pain initiates the fight or flight response in our bodies, triggering a cascade of physiologic events to occur in this already critically ill patient. When the sympathetic nervous system fires, circulating catecholamines increase, causing arterial vasoconstriction, leading to systemic hypertension. Consequently, this leads to decreased tissue perfusion and impairs blood return back to the heart. As a result, patients may experience impaired wound healing due to poor oxygenation and blood flow to those tissues. Other complications are venous stasis and platelet aggregation, which is dangerous when combined with immobility in the critically ill patient. This combination of factors can lead to the development of deep vein thrombosis or clots in the legs. Pain also commonly leads to agitation and anxiety. These factors can contribute to the development of delirium. Pain, agitation, and delirium are three entirely distinct but closely interrelated entities. Delirium contributes to increased mortality rates, making its management even more critical. Pain, agitation, and delirium contribute to dangerous patient occurrences, such as self-extubation, self-removal of catheters, and ventilator complications, such as ventilator-associated pneumonia due to noncompliance. Furthermore, pain, agitation, and delirium contribute to cognitive dysfunction and other mental health conditions. Overall, uncontrolled pain in the critically ill patients contributes to poor outcomes in the short and long term of these patients' lives. Self-report remains the gold standard of pain assessment and is a vital tool when attempting to determine the level of distress your patient is experiencing. However, when the patient is unable to state what they are experiencing, it is important for nurses to utilize other assessment tools. Based on a survey administered to critical care nurses, many nurses fail to utilize these tools due to a lack of understanding how they work. Another way to assess pain is to evaluate the physiological indicators of pain. These include increased blood pressure, respiratory rate, heart rate, diaphoresis, and a change in oxygenation status. These indicators are important to evaluate. However, using them alone to assess pain is not effective, as change in vital signs may be due to disease processes and need to be evaluated further. Using physiological indicators in conjunction with another tool may lead to better, more complete assessments. Another assessment tool is to use the hierarchy of pain assessment. This hierarchy starts with self-report as the gold standard, then moves on to evaluation of potential procedures which may cause your patient discomfort. These can include surgery, suctioning, repositioning, and many other common procedures in the critical care unit. Nurses must utilize clinical judgment to know how they must intervene to promote better patient outcomes. The third tier of the hierarchy is to observe patient behaviors. These can include facial expressions, body movements, muscle tension, and ventilator compliance. If the patient is showing obvious signs of distress, including grimacing, splinting, or fighting the ventilator, the nurse can then plan an intervention to decrease patient discomfort. There is a wide range of medications available to effectively manage patient pain. These range from NSAIDs to opioid analgesics. Most hospitals consider opioids to be the gold standard of pain management. The most common opioids seen in the neurological critical care setting are morphine, fentanyl, and remifentanil. Although opioids are very effective in pain management, there are side effects that need to be monitored and controlled, especially in this setting. The most common side effects of opioids are respiratory depression and decreased gastric motility. These side effects can both lead to increased intracranial pressure. Following a strict bowel protocol and initiating continuous monitoring of pulse oximetry and respiratory rate can provide nurses with a clinical picture of their patient's response to pain medication and how to better approach pain control. Another option for pain control is alpha-2 agonists, specifically dexmedetomidine or Precedex. Research shows that this may be a promising alternative as it provides the necessary analgesia and still allows patients to maintain the proper level of arousal. This is ideal as nurses will be able to obtain sound neurological exams. Common side effects of this medication include dry mouth, bradycardia, hypotension. All of these can lead to decreased cerebral perfusion pressure. This is seen most commonly with the initial dose, but it is corrected as the patient's body metabolizes the drug. Nurses should use clinical judgment on what is the best option for their patients and advocate with providers to find an option that promotes the patient's physiological integrity in all aspects. What does all this information mean for nurses? Be diligent in assessing your patients. Utilize all the tools available to obtain a good baseline assessment and be vigilant in observing for changes in your patient's behavior or their physiological indicators. Nurses can utilize the hierarchy of pain assessment in order to best determine which assessment method can provide the most information. Further, nurses should be proactive in pain control. Nurses spend a good amount of time with their patients and understand what works best for them. It is important to always utilize clinical judgment to determine what the proper level of analgesia is in order to maintain the proper level of arousal. And nurses should always look to determine what works best for their patient. The most important role that a nurse plays in all of this is to be a patient advocate. As nurses communicate with family members and providers, they become the intermediary and act as the voice of the patient who is unable to speak for themselves. This can lead to better long-term patient outcomes, shorter hospital stays, and a faster recovery. What role do you play in the silent battle? Utilize the knowledge you have and you can become the greatest advocate for your patient to further them along the road to recovery.